Our webinar today will discuss ketogenic diet for brain tumor patients. My name is Jillian Demas. I'm the Senior Program Manager here at the American Brain Tumor Association, and I am delighted to introduce our speaker today, Leonora Renda. Leonora Renda is an outpatient oncology dietitian at the University of Arizona Cancer Center at St. Joseph Hospital and Medical Center in Phoenix, Arizona, and is the lead dietitian for a Phase 1/2 clinical trial for newly diagnosed glioblastoma and the ketogenic diet. Leonora received her Bachelor of Science degree, concentrated in dietetics from Illinois State University, and completed her dietetics internship at the Arizona Department of Health and Services. She is currently working on her master's degree at Arizona State University. And just as a side note, Leonora is actually today with us, joining us from London. So I want to thank you so much for joining us today, Ms. Renda, and joining us from London. We really appreciate it. And you may now begin your presentation.
I want to thank you very much for the opportunity to be able to speak about this diet. Thank you very much, everyone, for joining. I hope that you will get a lot of information out of the webinar, and we can help in any way that we can as we move forward to work on brain tumors. Today we're going to be talking about the ketogenic diet for brain tumor patients. The objective for today would be to recognize the components of a ketogenic diet, we call it a KD diet, describe how to achieve ketosis in patients, and identify the challenges associated with this specialty diet, as well as increase your knowledge of results that have been seen thus far in our research studies. Just as a note, less than 5% of the patients diagnosed with a grade 4 brain tumor, which is called a glioblastoma, GBM, will survive for 5 years. Usually life expectancy is from 18 months to 5 years. Despite all of the advances in radiation, chemotherapy, and surgery, the survival rates have not changed in the last 10 years. GBM is the most commonly found brain tumor, as well as the most deadly. There has been an increased or renewed interest in cellular metabolic therapy as an adjunct therapy for cancer. Emerging research in both animal and case studies in humans suggests that a KD diet will stop or inhibit the growth of a GBM brain tumor. Remembering that life expectancy is 18 months to 5 years. Even if the brain tumor is a total resection, all of the tumor is removed, the tumor will reoccur around the margins of the removal. So this research is really interesting to see if we can stop that growth. The hypothesis is that a ketogenic diet during radiation treatment will prevent the tumor growth in adult GBM patients. And here's just a few other statistics about the tumors. There's a grade 2, 3, and 4 tumor, and you can see with the ages that the 5-year survival rate, you see where our rates are. So we're really working to try to increase the survival rates for all of our patients. The cancer metabolic pathways have really been studied since the 1920s. You can see in 1923, Otto Warburg observed that tumors convert high levels of glucose to lactate, even with oxygen present. We also found out that cancer patients have increased levels of inflammation, impaired glycogen synthesis, and increased breakdown of both protein and stored fat in the body, as well as an increased utilization of fats in the muscles and increased gluconeogenesis in the liver. Also, by increased metabolic glycolysis, the tumor's reliance on glucose is elevated. You see that the tumor really wants to feed on that glucose. The inflammation really is huge. I see a lot of my patients that will be losing weight when they come and lose weight during treatment. You see breakdown of lean body mass with protein as the protein is used for energy. So my patients have an increased need for protein. Their calories are 1/3 more than they normally would need to have. So a lot of my patients will say, I'm eating the same amount of food, but I'm still losing weight. That's because you have that increased need because of all these metabolic changes. Excuse me. Also, if you take a look at the cancer metabolic pathways, you'll see that gluconeogenesis increases. The patient's total energy expenditure, again, that 1/3 increase due to their resting energy expenditure, their activity level, and then their injury level due to cancer. You also see that the insulin sensitivity and glucose tolerance decrease, which again increase the blood glucose available for your cancer cells. So all of a sudden you see this huge increase of glucose in the body so that the cancers can use it to grow. You also see an increased glucose uptake, which is due to an overexpression of some of the transporter hormones. You'll see glucose transporter 1 and hexokinase both overexpressed, and it's just using that glucose. The glucose is able to be uptake. You'll see the glucose uptake of the muscle and the glycogen synthesis leads to that extreme fat loss and muscle wasting in cancer patients. A lot of that falls around cancer cachexia, where you see that all of the food is being used for energy, as well as the body being broken down to be used for energy to help the growth of the tumor. Glucose is the preferred energy for all of our body cells. Normal cells use it all the time. The cancer cells love it. But also our normal cells can use keto bodies, which comes from fatty acids, for energy under fasting conditions. So if you think about it, when primitive times, we may not have a lot of food around. So the body had to be able to utilize the fat stores to supply energy. Even when fasting, the insulin and glucose levels decrease. Glycogen, free fatty acids, and your ketone bodies are going to increase. Here's a little diagram of what gluconeogenesis looks like, so you can see how the body is using the amino acids as well as the lipids for energy and glucose for the blood. So it's a little schematic so you can see how it's used. The stored glycogen in the liver is used again for energy and broken down so that we can use that as well as the fats and the proteins for energy. So what is ketosis? Ketosis is the condition where levels of ketone bodies are high in the blood due to the breakdown of fatty acids in the liver. Ketosis happens when there's not enough glucose in the bloodstream, and then the brain and the body can then use the fats for energy so that we make sure that the body is able to run. It's important that the brain can use the fats also. The fatty acids are metabolized instead of glucose, and through that metabolism, the excess ketones then begin to accumulate and appear in the blood. The ketones are produced in the liver from the fatty acids, and there's 3 different kinds: acetylacetate, beta-hydroxybutyrate, and acetone. The 2 that we measure are the acetylacetate and the beta-hydroxybutyrate. For our patients, for brain tumor patients, newly diagnosed GBM patients, this is the standard treatment. Normally you'll see a craniotomy, which could be totally resected and debulked, hopefully, or partially. That would be the surgery part of that. The next step would be external beam radiation therapy given concurrently with temozolomide. And that goes together, both the oral chemo as well as the radiation. Usually the radiation lasts for about 6 weeks. You are off 3 weeks to 4 weeks before you're then put back on the temozolomide, the chemotherapy. It started 1 month after the chemo radiation therapy together. So normally when a patient comes in for treatment, this is the standard that will happen for those GBM patients. Throughout this, 99% of the GBM therapy includes high-dose steroids to reduce edema and swelling in the brain, post-surgery and during radiation. We want to really keep the edema down as much as possible because that swelling creates all kinds of physical and mental issues. So we really try to keep that down. During that treatment, however, we know that the steroids potentially raise blood serum levels of glucose. And so they are constantly giving an abundant supply of glucose and glutamine. We know that the elevated serum glucose levels during GBM treatment predicts usually a poor prognosis. So within that steroid-induced therapeutics, we really take a look at that, the steroids, to help, but we also know that it may not always give a good prognosis after treatment. I want to shift gears a little bit and talk a little bit about the ketogenic diet. The ketogenic diet's been around for a long time, since the 1920s. At that time, it was used as a treatment for seizure disorders. Presently, 15 to 45% of all cases are inoperable with epilepsy, or they have a medication-resistant strain of epilepsy. So that we know that that's a large amount of people that we need to really help. The ketogenic diet does that. It's administered under the care of a neurologist and a registered dietitian nutritionist. We also require pre-laboratory evaluation before any patient would be seen this. Usually we see this mostly in pediatric epilepsy. That's where most of the patients have that. Those patients are actually growing so that we know that the patient can be on the ketogenic diet and actually not lose weight, but also continue to grow and develop throughout the adolescent years into adulthood. The ketogenic diet is widely accepted in varying cultures and cuisines across the world. Here, we're at the conference I'm at in London, we're talking a lot about how to cook with the ketogenic diet with all different kinds of cultures and really be able to maintain that diet and remain the treatment for pediatric epilepsy. The ketogenic diet is calculated by using a ratio of fat content to combined carbohydrate and protein content. We have several diets. There's a 4-to-1 ratio, 4 parts fat to 1 carbohydrate and protein. There's 3-to-1, 2-to-1, and a 1-to-1. But what we consider the classic ketogenic diet is an individualized and structured meal plan based on the needs of the patient. Within that meal plan, there are special recipes that are provided. All the food within that program is weighed in grams, and the meal must be eaten in its entirety to get the best results. Diet management may also include a medical food with that 4-to-1 ratio of fat to carb plus protein. Again, we have the 3-to-1 and the 2-to-1 also. But sometimes you can use a medical food formula that's really been constructed to maintain that ratio. Our medical nutrition therapy protocol starts with a diet initiation. We want to be able to burn the glucose out of the body and switch the body from using glucose as a fuel to ketones. In order to do that, we will reduce the calories to the resting energy expenditure of the patient, and that's called the REE. That is the amount of energy a patient would need to survive to metabolize their food, for the brain to function and the lungs to function if they were laying down throughout the day. So we look at that resting energy expenditure. On this diet, we limit the carbohydrate to at least 10 grams a day. Again, we're trying to really limit glucose and allow the body to burn off all the stored glucose that it has. Usually for my patients, it takes 3 to 5 days for that to happen. And after the patient is in ketosis, we go to the diet maintenance part of this diet. And the diet then can be liberalized to approximately 20 grams of carbohydrate. And then we look at the protein needs of the patient, and we try to increase the protein to meet the patient's needs. This diet does have some side effects, and I want to address the side effects as well as what we can do to combat the side effects. This diet is low in vitamins and minerals. In order to make a difference, we add multiple daily vitamins and minerals to be taken. My patients usually take up to the daily value that is needed. We don't make a dose. We keep it just at the daily value that a normal person would need. A person can develop high cholesterol on this diet. Sometimes they do, sometimes they don't. If a patient enters into the diet already with a high cholesterol, what we will do is we will switch the diet to revolve around healthy fats such as olive oil, canola oil. It could be sunflower, safflower. It could be also MCT oil. But we really try to target those healthy fats. Another side effect could be constipation due to the lack of a lot of fiber into the diet. What we use is over-the-counter medications such as Miralax, Senna, Dopalax. Any one of those can be used to really help promote regular elimination and prevent constipation. Some patients will walk in saying, oh, I don't want to lose any weight. We can actually maintain the weight of our cancer patients on this diet. Again, I will increase the diet after the patient has been in ketosis to their total energy expenditure to make sure that we're looking at their needs for activity as well as their needs for being from cancer along with their resting energy expenditure. I monitor the weight very closely with my patients, and if we notice that there is a decrease in weight, we can always up the calories. And remember, this diet is used in pediatric patients, and in doing so, we make sure that the patients have enough calories so that they continue to grow and develop. Kidney stones can also be presented in this diet, and to prevent that, we really encourage our patients to drink adequate water. I would like my cancer patients that we drink at least half a gallon of water a day, if not more. We live in Phoenix. That's where my practice is, and we know that it's very hot. We also know that the patients need to have extra water, but we want them at least to do that half a gallon to help prevent kidney stones. Some patients develop an upset stomach or a more acid stomach based on the diet. And we neutralize that with a 1/4 tablespoon of baking soda in 60 ounces of water about 4 times a day to really help relieve that upset stomach. And that usually happens in the patients if they've been on the diet over long term, maybe 5 weeks, 6 weeks, I usually see it present then. I wanted to include a sample meal. This is for a 2,000 calorie diet. So you can see it's Egg Benedict. A major component of this diet is heavy cream. It's used to help my patients achieve their fat requirements. So you can see this diet has about 65 grams of cream, 36% fat, 48 grams of butter, 14 grams of Canadian bacon, and we do the brand so that they can make sure that you have the correct nutrient analysis of the food. 16 grams of eggs that's raw and mixed well, 5 grams of Kraft Deluxe Deli American cheese, and 15 grams of strawberries. The instructions are very simple. You mix the cream and the eggs together, mix in the melted butter, pour into a frying pan, scramble the eggs, serve the eggs on Canadian bacon, top with shredded cheese, and serve with fruit. So this would be an example of a breakfast menu. So you can kind of see how it pulls together. Again, we're trying to both meet the protein requirements with the egg, Canadian bacon, and cheese, as well as the fat requirements with the cream, butter, the egg, and the cheese. And their carbs for this meal come from the strawberries. Here would be another sample meal, just a little different. So you can see that not a whole lot of preparation with this meal. It's a beef patty with fruit and sugar-free Jell-O. So it has about 90 grams of cream, and this cream has 50 calories from fat, 17 grams of cantaloupe, 30 grams of Jell-O, the sugar-free Jell-O prepared, 52 grams of beef. And notice it has to be the 70% calories from lean. So we know that 30% of that will come from fat when it's cooked. It's cooked with oil. You'll see 15 grams of canola oil, and then 22 grams of cream cheese from Organic Valley. So in this meal, you can do a couple things. You could take the canola oil and add it to the cream, whip the cream, and add some liquid stevia to it to make it like a dessert. You could then also take the cream cheese and use that on top of the burger. Whatever we do, we want to make sure that the fat that is cooked in with the beef is also included into the diet. We usually add that into the diet so they have that together. You can use an oil spray or grill the ground beef patty, weigh it when it is cooked, and then there's a cooked 52 grams of ground beef. So some recipes will be raw, some recipes will be cooked. And I wanted just to include some of the tips to incorporate fat into the diet, because it seems to be the hardest piece to pull through with this diet. Some of the suggestions are to use a high-fat meat, such as roast beef, pork chop, shellfish, would all work into creating that higher fat meal. We suggest using heavy cream as a part of every meal. Again, you can whip the cream with some liquid stevia or vanilla extract in it to make it more like a dessert. Some patients like to add the cream and the fruit together to make more of a fruited dessert. You can take and add water to the cream to make it taste more like milk. You can add whipped cream to diet root beer to make it more like a diet root beer float. Or you can actually use the cream with the hot chocolate. And if you use the unsweetened baking chocolate, that's a good way to add that into it to give a different flavor. Some of my patients actually like to do the meal and then pour the cream over the meal because they feel that makes it more like a cream sauce for them. You can also mix butter in with peanut butter or cream cheese to add that extra fat in. Add the oil to the cream. Also would be another good way to incorporate fats into your diet. Mayonnaise is a really simple, easy way to increase fats without having to increase a lot of oil. So you can add that in with chopped meat to make like a meat salad or an egg salad or a tuna salad. I also use the condiments for my patients. Mix it in with some of the lettuce. Lettuce is a really good way to be able to incorporate the carbs in, a lot of carbs for the volume and grams. And then some people will do like a chicken salad. They'll put their sliced chicken on it along with their dressing, their heavy fat dressing. They can put some mayonnaise in with it. Sometimes throw some pecans on, all good ways to add a little bit more fat to their diet very easily. You also can reheat cooked butter in a small pan, a good way then just to be able to, use it again. Put your cooked meat in there, reheat it with butter, and that will add some more fat. And a real simple, easy way to help is to maybe put a pinch of herbs in with your softened butter to give it more flavor. A lot of times when I do vegetables for my patients, I'll suggest that butter to put on the vegetables just to increase their fat content without having them use a lot of oil. I do have one patient that would just very easily drink the oil. So there's lots of ways that we can incorporate that in. It's patient-driven, so I usually work with my patients to really help them make the best way to incorporate that into their diet. Another really good way is they have a simple eggnog recipe, which will enable them to add a lot of cream and fat to help. But this would be one of the hardest parts of the diet to really not get tired of. I hear a lot of patients are tired of eating the fat and are always looking for a new way to incorporate it in. So we try to really offer these options so the patients are able to stay on the diet and maintain their fat intake. Another popular diet is called a modified Atkins diet. Sometimes you'll see this as a modified ketone diet. It is a little different because the calories are are portioned out for fat, protein, and carbohydrates. We take the total energy expenditure for the patient and say 60% of their calories, total calories, should come from fat, 30% of the calories should come from protein, and about 10% of the calories should come from carbohydrates. This diet can be measured in cups and ounces, and they can use a standard meal plan as a guide for the patient. The diet limits the amount of carbohydrates, encouraging the fat, and really liberalizes the protein. So they're able to have a lot more protein than you can, per se, on a classic 4-to-1 ketogenic diet. The carbohydrates are consumed throughout the day, but not to exceed more than 20 grams. And again, the protein is not limited. This diet has been able to maintain ketosis also. It is initiated the same way that we initiate the classic ketogenic diet, by restricting calories and then liberalizing the calories after the patient is in ketosis. So this diet just is a little more user-friendly when you go out to restaurants. Usually with the classic 4-to-1 diets, a lot of my patients will bring food with them in order to maintain their 4-to-1 ratio. But with this diet, the patient is able to eat a little more liberalized diet at restaurants and carry forward. Saying that, I do have a patient that's on the classic 4-to-1 diet that was going to a special dinner with his wife at a restaurant, and I was able to work with the chef to take the existing recipes for the meals for the patient, and we were able to really make them into a 4-to-1 ratio for the patient. So the patient was able to go out at the restaurant, enjoy a nice meal with his wife. So there's lots of things that we can do at both the classic and the modified diet. There are a couple more, but for what we're looking around cancer and brain tumor, it really revolves around these two diets. So the hypothesis that we've been working on with cancer in the diet is that we know that cancer is a metabolic disease that may be able to be managed through systemic metabolic therapy using metabolic control. The brain can use both the glucose and the ketones for energy, while the tumor relies solely on glucose for energy. So the basis of our theory is that in a physiological environment, glucose restriction of the tumor cells may result in slower growth, it may cease the growth, or cause cell growth of the tumor. And that's what we've been really looking at the past 2 years. We think that the ketones may be toxic to the cancer cells and may restrict the availability of glutamine to the tumor. We also think that the ketogenic diet induces ketosis, which can cause changes in the brain's homeostasis. Therefore, it's logical to look at the research for the effects of the ketogenic diet and ketosis on GBM brain tumors. So our goal is to see what we can do to kind of extend quality of life, as well as maybe slow down the progression of GBM cancer. There's been studies that have gone since the 1912 that talk about what happens within the ketogenic diet and around glucose and around cancer. In one study in 1912, the researchers were feeding rats a carbohydrate-free diet and free diet of casein and lard that decreased the tumor growth and helped with decrease the mortality rate. So we knew at that point in time that everything was just a little slower. In 1921, they observed that glucose secretions in the urine disappeared in the diabetic patient who developed cancer. So all of a sudden there was no glucose in the urine, and that's a lot of, at that time, how we monitored diabetes at that time. They also noticed that there was a higher consumption of glucose in cancer tissue compared to the muscle and liver tissue. So all of a sudden we noticed that something was going on between cancer and glucose. In 1995, 2 pediatric patients with grade 3 astrocytoma tumors were treated with the ketogenic diet, and both responded well to that treatment, and both reported tumor management with this diet. So that was very exciting to see that restricting glucose and increasing ketones really helps with the management of that tumor. In 2010, in a case study, there was a female patient with a GBM who followed a calorie-restricted diet. So they reduced the calories. It was a ketogenic diet. And what happened was that the diet in this patient stopped the growth of the tumor. But it also reported that there was a 20% loss in her body weight. While the patient was on the ketogenic diet, she was able to restrict the growth of the tumor. When she went off of the diet, the tumor actually grew, and the patient did succumb to the disease. But it was great to see that growth of the tumor was able to be stopped. In 2009, they looked at the results of non-calorie-restricted ketogenic diet with a GBM patient. And what they saw is that it suggested that there was an increase in the anti-tumor activity, which means the activity that would not cause that tumor to grow. In 2012, in an animal study, the ketogenic diet and/or calorie restriction led to increased production of the keto bodies. Again, that's the metabolism of the fatty acids. It also showed a significant decrease in glucose production and the proliferation of cancer cells, as well as an increase in survival rate. So all of these studies really were animal studies, small case studies, all leading up to really saying, what can we look at for the patients in humans with GBM? So we know a couple things. We saw an overall change in the gene expression of the tumor versus non-tumor tissue. So what that suggested is that the ketogenic diet may be useful in the treatment of GBM. The ketogenic diet may serve as a protector of normal brain tissue during treatment. The study results also suggested that the ketogenic diet's effect on tumor growth was not so much due to a reduction in glucose, but what we think is more likely due to a change in the gene network and the interactions that regulate the signaling and the homeostasis mechanisms of the cell. So actually more of a cellular change in the genes rather than just starving the tumor. So this is going to look, this slide is from one of the research studies, and you can see that taking a look at the ketones as well as looking at treatment, the BCNU is a standard treatment of chemotherapy plus the ketones together actually showed responses in the growth of the cells. So what you see is a decrease in how the growth of the cells when the patient was on the chemotherapy and ketones. You also see the normal ketones what they did to slow down the growth. You also look at the growth of just the chemotherapy, but combined you see that there is a huge increase in reducing that cell growth. So this has really become very exciting that we're actually looking at some standard treatment along with the ketogenic diet to make an impact on the cell growth. And then we take a look at the beta-hydroxybutyrate level of the patient. So you can kind of look at this and see beta-hydroxybutyrate is the excess ketones that will be in the blood. So when you take a look at the study, you can see that as you look at the blood, you see that on the ketogenic diet with keto-cal, which is the blue line, we'll see an increased level in the ketones availability in the body. You also see with the keto-cal diet and radiation in a mouse study a total increase in the level of ketones in the body. You can see it on day 6, post-implantation of the cancer cells, and on day 13. You'll see that the ketones are extremely high on that diet. So that means that the body is actually using the ketones, transferring over from glucose to the ketones with the levels being high with the diet. And then you can take a look and see the glucose part of it. Remember, we want to manage both of those. And you can see that the glucose is going to be higher in the standard diet and higher during radiation, and again lower when you add the ketogenic diet, both to radiation and chemotherapy. So we're looking to reduce the glucose as well as increase the ketones for energy. In 2010, you'll see that the findings from a research study yield that the effects of the ketogenic diet on anti-tumor activity during radiation. You see a decrease in that. You'll see the increase in the anti-tumor activity during radiation in the mouse model. The ketogenic diet did very little to affect the weight of the patient. You'll see that the symptoms for both standard diet and for keto diet were the same, with a decrease in body weight. The ketogenic diet had no difference from a standard diet as around weight. So you can see here's the weight post-implementation. You'll see the standard diet and the keto diet pretty much maintaining the same area. You'll take a look at the standard diet plus radiation as well as the keto diet and radiation. And you see much better results around the weight with the keto diet and radiation combined versus the standard diet and radiation. And then post-implementation, you'll see as far as chemotherapy, both you'll see the results again for the chemotherapy, both in a standard diet and a keto diet, just about the same as you take a look at that. So no difference in that area. The biggest difference for the weight gain was the keto diet and radiation. As far as survival in the mouse model, this is looking at the standard diet as well as the keto-cal diet. It's significant. You're going to see a drop-off in the survival rate of the standard diet at about 36 days after implementation, and you can see a decrease in the rate in the keto diet out to 50. So you'll just take a look and see what is looking from that area. So you can take a look and see the difference in that area. If you take a look at the standard diet and temozolomide, as well as the keto diet and temozolomide, you'll see that post-survival rate at that implementation, again, was about 30 days on a standard diet. And you see about close to 50, 45, 50 days for the keto diet and the chemotherapy combined. So as you look at that, you'll see the little bit increase of life expectancy with that survival rate. If you take a look at this slide, this is a very interesting slide. This is standard diet and radiation plus standard diet and the keto-cal diet. So if you take a look at where we're at, the standard diet, majority of the mice died within probably the first 55 days. We have one outlier that went to 150 days. If Interesting to note with that outlier, that mouse actually lost weight on its own. And through that weight reduction and lost weight, they were able to survive longer than the rest of the diet of the mice. But you'll see that it's connected with the weight because the weight dropped. So you'll see that's where the difference is. If you look at the diet around keto and radiation together, you'll see that the mice did not die. They actually lived to almost 300 days. We sacrificed them at that point in time, but you can see that life expectancy in a mouse model went from standard radiation with a decrease in survival rate to the mice surviving a long time, both with radiation and chemotherapy. Very interesting piece to look at to see what actually happened within that model. So this is the bioluminescence MRIs from the mice. We actually implanted the cancer into the mice with those bioluminescence so that when the MRIs were done, you could actually see where the tumor is. So this takes a look at radiation in keto diet together. So you'll see day 3 through 12. And at day 15, you still see the tumor, but then at day 18, you're hard-pressed to see any of the tumor left. And we go from day 36, 48, 60, 72, 84, 110, 122 to 134 with no reoccurrence of the tumor. The diet was switched so that the patient went off of the classic, what we would say the keto diet, a classic 4-to-1 diet, onto a regular diet and lived to day 300 with no tumor regrowth. This picture talks about what happens with tumor size at death on a standard diet. So we're switching gears from looking at what happens with the keto diet and treatment. We're just looking at the diet as a whole. And it's really interesting because we see that the tumor size in the standard diet seems very small, where on the keto diet, it's bigger. We were actually able to take a look at the size of them with the bioluminescence. And so that begs what happened within that model and what was the difference. Usually within the cell, at death, we will see the tumor and edema, the swelling, being both causes of death. It's the tumor burden that we look at. So we wondered what that meant with the keto diet and the standard diet. So we took another look at what was going on with edema in the brain. So we wanted to see the MRI measurement of edema and what was happening. And what we found is we took a look at the tumor signal. So we were able to take a look and see what the tumor looked like, what was the size of the tumor, but then we wanted to take a look at the measurement of edema. So this is important because we can see there was a high level of edema that was happening in the standard diet versus the low part of the edema that was happening in the ketogenic diet. What that tells us is that we think there is the connection between edema and the standard diet and edema in the keto diet yielding less of the swelling and more of the tumor growth less, rather than looking at the size of the tumors being the same. So we know that edema played a huge part in the standard diet, where in the keto diet it was very low, which is good. Always trying to prevent the edema in the brain due to the tumor. So another study that really started talking about the keto diet was done in 2013. And this diet was in human studies. It was a retrospective study. And the findings of this study yielded low serum glucose levels during GBM treatment, and that those low levels may improve the clinical outcomes for the patient. So from August 2010 to April 2013, 6 patients with grade 3 and grade 4 glios followed the ketogenic diet. The patients studied underwent tumor resection and debulking. They followed standard treatment with no signs of progression. So remember, we talked about the surgery to remove the tumor, the 6 weeks of radiation and chemotherapy concurrently, followed a brief break, and then chemotherapy. So this study showed no signs of progression in that 2-year period. The patients received education on the diet. They received books that they were able to use as well as direct education. They also managed their diet, keeping their carbohydrates to 50 grams a day. A little different from what you look at from the classic ketogenic diet. They liberalized the carbohydrates. In those patients who did not achieve ketosis on this diet, they then restricted the carbohydrates to 30 grams a day, and they limited the protein as needed. So in other words, they dropped the requirements a little to see if we could get the patient into ketosis. We were able to get the patients into ketosis. They monitored that with looking at the urine ketones using a ketone strip for 2 weeks. And then they switched to the serum glucose and ketones using a glucose ketone monitor in finger sticks. And they also collected all of the diet information around their diet. Their non-fasting glucose levels for these patients were between 76 and 93 milligrams per deciliter. Treatment results showed that the ketogenic diet was safe and well tolerated during standard treatment of high-dose steroids. That's really, really important. Those high-dose steroids that we talked about earlier actually infuse the body with glucose. So this showed that even with glucose, we were able to keep their glucose levels lower and that we were able to achieve ketosis. So the respective data shows or suggests that the dietary restrictions of carbohydrates through the ketogenic diet reduce serum glucose levels significantly, even in conjunction with the high-dose steroids, which may affect their responses to standard treatment and to better prognosis. So a very interesting study, a very small study of just 6 patients, but it's really interesting to see that we were able to achieve ketosis with steroids during standard treatment. The institute that I work at, St. Joseph's Hospital and Medical Center in Phoenix, and also Barrett Neurological Center, as well as University of Arizona Cancer Center, has a clinical trial for GBM presently going on in human subjects. People that are involved in this study are its primary investigator is Dr. Adrian Scheck, myself as the clinical dietitian. Narissa Honla is our PhD who's involved in the quality of life. Dr. Lynn Ashby and Dr. Chris Stardust are our 2 neuro-oncologists that we're working with. We're using the ketogenic diet as adjunct therapy along with standard treatment in our patients with grade 4 GBM patients. We're looking at overall and progression-free survival, which is the goal of our study. We're also looking at the quality of life of patients during treatment as well as their cognitive quality of life. We're doing neurocognitive testing. Narissa is doing testing before treatment and then after treatment to look both at quality of life and the neurocognitive effects. We're looking at changes in seizure activity, steroid use, and or edema to see if we can decrease steroid use, decrease edema, and also decrease that seizure activity. Our patients monitor their blood glucose and ketone levels daily and keep track of that. They look at the diet effectiveness, and we look at those levels to see if I need to adjust the diet with the patient, either decreasing calories, increasing calories, ways to increase carbohydrates, or decrease as needed within the patient. That's really how we're monitoring how the patient is doing as far as ketosis. We are able to get from the RSG1 Foundation a keto kit, and the keto kit includes a scale, glucose ketone meters, and strips, as well as urine strips for our patients to use. Our goal is to have our ketone levels above 3, preferably around 4, and to keep our glucose levels around 70. Our patients are monitored for uric acid, cholesterol, triglycerides, LDH, acidosis, and we also look at the free carnitine. Sometimes with the diet, carnitine may be decreased and we may need to supplement. So we will do lab tests to really see where our patients are. Kidney stones, we're looking at the cholesterol, triglycerides, acidosis, as well as the carnitine. We also are looking at health-related quality of life testing to see where they fall within that area. That is extremely important. We want good quality of life on the diet during treatment. We also look for changes in seizure activity, changes in anti-seizure medication, changes in steroids. We're looking at neurocognitive assessments. We're also looking at molecular tests. We're looking at myelination to see what's happening as far as that area within the brain tumor. These radiation guidelines for our patients, we want to make sure that we are able to give them the gram scale to use to measure their food, the precision extra glucose ketone monitor with strips. They will receive the urine strips, as well as instructions on how to use the glucose ketone meter and the urine strips. We also have them monitor those levels so they do receive a chart so that we can really keep track of them. I also work with our patients to develop their meal pattern that best suits their needs. Some patients want to be half snacks. Some people would prefer more snacks or less snacks. I also work to make changes for the palatability of the diet to make sure that the meal pattern really is tailored to their needs. I have some patients, for instance, that will want to eat fish more than red meat. So we have to work within that diet pattern so that they can actually use that diet. I work with a program called Keto Calculator. In order to work with this program, the patient has to work with a registered dietitian. We work together as partners in the diet. The dietitian will set up the calorie requirements and the specific ratio of ketones to fats to glucose and protein together, as far as the palatability of the diet. So I will put that together for my patients. My patients then come in and are able to create use meals, standard meals. For example, the eggs Benedict and the beef, the fruit, and the Jello are a standard meal pattern that they could have. Or I work with them to create a meal pattern that they like, a recipe that they like. The Keto Calculator has the ability for the dietitian to enter new food products if there's a food item that one of the patients would like to have. I have my patients in the store take a picture of the nutritional analysis of food and send it to me, and then either on Gmail or by text, and then I'm able to enter that into the Keto Calculator so the patient can then use that product as a part of their diet. I have very resourceful patients that will be out looking all the time for something new that they like that will meet the fat requirements for their menu. So we work very closely together, but they have to have access to a computer and, again, working with myself. The patient also has to agree to the following lifestyle changes. We want them to take a multivitamin daily. Drink at least a half a gallon of water daily. Focus on non-starchy vegetables such as cauliflower, broccoli, lettuce, staying away from potatoes and corn and green peas and winter squash, which are more of the starchy vegetables. They have to be able to eat foods high in fat, such as heavy cream, avocado, butter and margarine, mayo, and olive oil. We need them to have at least 3 meals a day, and then with or without snacks. It's somewhat better for the diet if you're able to eat the snacks with the meals, because then that, again, just continually feeds the patient with the fat and that the ratio of fat, carb, and protein together in order to supply energy for the patient. So my patient has to be able to make those changes, as well as being comfortable at doing a finger stick to test their blood and their ketone levels daily. This would be the protocol that we would follow nutritionally for the study. 1 week prior to radiation, I meet with my patients, their family members, or caregivers to talk about the diet. At that time, I give them a sample 1-week menu to look at, as well as the recipes that accompany that menu, so that they have a clear understanding of what the diet looks like, how they can prepare the diet. I try to do a variety of different meals, to make very simple meals to more complex meals, depending on what the patient would like to do. Some people like to cook. Some people like to make it as simple as possible. Some people like to use the keto-cal formula as a part of their meal. So we actually look at that menu. We discuss about how to get onto the keto calculator, how to select meals. They actually pick the meals that they would like to use. I go in then and look at the recipes, make sure that it's a proper ratio of fat to carbohydrates plus protein. I calculate it, I verify it, and then the patient is able to print the diet off, the recipe off, and use it. The patient will begin the ketogenic diet 1 week prior to radiation therapy. That calorie initiation requirement is reduced to the resting energy expenditure. That is based on the weight, the height, and the age of the patient. So I'll take a look at all those factors to come up with their resting energy expenditure. The patient must monitor daily their glucose and ketones using the meter, and they report that to me, especially within that first week closely, because we want to make sure that they're in ketosis. So usually, like I said, 3 to 5 days after the initiation of the diet, ketosis is usually achieved, and then I will liberalize the diet to meet the patient's total energy expenditure. There are times that I've had patients go into ketosis after 1 day. I've had patients that it took about 7 days for them to go into ketosis. So we really monitor that. It's very individual, and we'll look closely at it and do everything we can to get them in ketosis. Once they're there, we liberalize everything. If unable to achieve it in the 5 days, I look at the cooking procedures, the food intake, medication, any labs, and modify the calorie intake and meal plan as needed. During radiation therapy, their calorie requirement is increased to their total energy expenditure, and we base that on the weight stability. I look at the calories that they eat. We look at how stable they are with their weight. Sometimes we'll add an additional snack if I notice that the weight is dropping. So we try to really maintain that weight stability. Again, the meal plans are directed by me, and they consist of the 3 meals a day and snacks as needed. A typical diet is a small amount of fruit and or vegetables, protein-rich foods, and the majority of their calories are consisted from a source of fat: butter, vegetable oil, heavy cream, avocado, mayo, nuts. All of those things would work into their diet. They monitor their levels, again, throughout all of radiation, and also we use over-the-counter medications for constipation. During radiation, several things usually happen with any cancer patient. I will see that the patient is a little more fatigued during radiation treatment. I also see that sometimes the patient has a loss of appetite normally, just with cancer and then also during radiation. So those are all normal side effects. Within this population for our study, we really try to monitor those and really help the patients to be able to achieve the diet and then really manage any side effects that come with it. Post-treatment, our patients will continue on the classic 4-to-1 ketogenic diet for 4 to 8 weeks after the completion of radiation. We do that because we know the effects of radiation last 2 to 4 weeks after completion, and we want them to get every benefit they can. I usually recommend that the patient wait for their first scan after radiation treatment. And then when they move on to the chemotherapy section, the next part of standard treatment, the patient can transition to a modified Atkins diet if they choose. I have some patients that want to stay on the classic 4-to-1 diet, and some do choose to move on to modified Atkins. I want to present one of the case studies that we have with one of our patients to show you how the plan works together. We have a 37-year-old woman that had a large anaplastic astrocytoma. The treatment consisted of subtotal resection. In other words, we were unable to get all of the tumor out. It was followed by the ketogenic diet with radiotherapy and concurrent temozolomide chemotherapy, followed again by the chemotherapy afterwards alone by itself. Over 1 year after surgery, there has been no additional tumor growth, and the patient is clinically improved. Health and therapy-related quality of life measurements are also shown. She's done extremely well within that area. This is some of the scores that we have for the functional assessment as far as what's happening within the brain tumor, the patient. Yes?
Nora, this is Jillian.
Hi.
We're about 6 minutes over, and we have a lot of questions.
Okay.
Do you mind skipping to the conclusions, and then
Absolutely.
we can try to ask a few questions because it's about 6 minutes over the top of the hour.
Okay, thank you, Jill.
Sure.
Okay. I'll just go through these quickly so you can kind of see the patient was able to maintain ketosis. You can also see that this is a post-scan for where the tumor was 1 month after to some of the age, 16 months, 15 months, progression-free. This regime is safe and well tolerated in all patients. The results are preliminary. The clinical and MRI findings are encouraging. There may be an improvement in the quality of life in addition to the time to progression, which is awesome. Functional status is generally well preserved through treatment. In individual cases, the diet was tolerated long-term. Weight stability was achieved, and again, this is the study. We'd like to do other studies too that we'd look at continue. So, references, and we're done. Okay.
Thank you. Sorry about interrupting.
That's okay. Sorry.
That's okay. One of the major questions, probably about 8 to 10 of them, were for individuals who are wondering if this is for only GBMs. They're wondering if it's for other tumors. We've had questions about oligos as well as meningiomas.
I have been working, it is only for GBMs. It can be for other patients. Our research is focused on GBMs because of the mouse studies, but we do know it can be open to other tumors. And it doesn't have to be just brain tumors. It could be, we're thinking breast and other ones. And the case study that I presented was an oligo tumor.
Thank you. Second, probably most common asked question is, how does someone find a dietitian who is familiar with this type of diet?
You know, a lot of the dietitians that work with this diet deal with pediatric epilepsy. That to me would be a good place to start. The conference I'm at, a lot of dietitians are looking to start expanding their practice to look with cancer patients. So I would say that they always can contact me. I can help find someone or to take a look within their other areas to see if there's someone that they can really work with. So that would be my suggestion. Look for the pediatric epilepsy and see what is out, patients are out, which clinicians are out there.
Okay, and then some more specific questions about the diet. People are wondering about what if I am a vegetarian, what if I don't drink dairy, what about food allergies? How easy is it to make substitutions to the diet plans?
It can be very easy. I am working with a patient who is a Greek Orthodox monk where he does not drink any of the cream. So as we take a look at that, we are using olive oil and pecans and avocados and mayo. So we are not using the cream. So you can make those adaptations for the patient. Vegetarian, you can take a look at other options. We have to be cautious because we have to make sure that the carbohydrates are still low, but we have to really also take a look at what we can do to maintain that protein requirement for the patient and not boost the carbohydrates. So yes, as far as food allergies, I tailor-make each of my diet plans with the patient. So I have patients that will not eat fish, or patients that don't eat red meat, or patients that can have problems, allergies with maybe some of the fruits or vegetables. We really work through it one-on-one, so we can really kind of tailor it to the patient.
Perfect. And the last kind of one I see a theme of is this for people who are in treatment, or is this for people who are survivors who are maybe trying to just maintain their survivorship?
I can't speak to the survivorship piece of this. I do think that for me, the survivorship diet that I would look at if I wanted one in this avenue would be the modified Atkins, because I think that is the liberal one that you can do a little more easily without so much assessment by a dietitian. It's much easier to do within real-life scenarios. You can do the classic 4-to-1, but I think you have to continue to work really closely with the dietitian so that they're monitoring all those side effects that can come up because of the diet. So, I would think in treatment, anytime that you can limit or lower the glucose in your diet, increase the ketones, I think it's a good idea. We don't have clinical research, again, that shows that, but anecdotally, following the premise of this diet, I think that it might be beneficial. We don't know yet. And again, what's great about this therapy is it does no harm. It doesn't hurt you in any way. There are no really potentially harmful side effects that come from it. You can deal with the constipation. You can deal with high cholesterol, lots of things to do. Very easy to make those changes.
Great. And do you recommend anyone doing this without your clinical support? And what's the age range? We've had people ask questions about their 83-year-old mother to their 3-year-old child.
That's a really interesting question. When you look at what happens with epilepsy, pediatric epilepsy, very young children do it. You're able to do it very young. 3-year-olds, of course. 83, if they can manage it and the quality of life is there, if they're able to make those adaptations, yes. I have one patient where the daughter says, she eats anything I give her, and the mother says, yeah, whatever she gives me, I eat. So it's going to depend on the patient, but yes, across the board. Some of my patients are in their 60s and 70s and 80s. I have some patients in their 30s and 40s. So it's a broad spectrum, and I think it really just depends on the patient. and their willingness to make this change and to really follow it. Yes, and I do think if you're going to be on any kind of a ketogenic diet, you must meet with a dietitian to at least get on the plan and to understand the diet, because it's not the Atkins diet that you think of for weight loss. It's Atkins diet on steroids for the modified Atkins diet, and the 4-to-1 is really medical nutrition therapy. So I really encourage a dietitian. And there are 2 sources of dietitians out there that might be helpful. In the United States, there's a foundation called Charlie Foundation that deals with epilepsy, and they're starting to look at cancer. They may have resources and dietitians within that area. And then Matthew Friends here in Europe is really the one that's pulling forward with the research and really trying to bring people together. And I would go to their websites and take a look at that, Charlie Foundation and Matthew's Friends. They have cookbooks, they have information about all of the diets. It's a great resource for everybody.
Wonderful. And you did mention that people could contact you. Do they do that through the university?
Actually, we can put my email address up somewhere, and if we could do that, they could contact me through that.
Okay. Okay. We can put that at our website later on when we post the webinar, if that's okay with you.
Right.
Okay.
That's fine with me.
Perfect. Okay. Well, we're beyond the time, so I thank you for extending your time with us. I really, really appreciate it. And I appreciate everyone for hanging on with us. I am going to refer everyone back to our website, where we will have this posted in just a few days. It will be posted to our Anytime Learning section. So I am going to pause and stop our recording, and then I'm going to tell you about some future webinars that we have coming in the next few months. One moment. We invite you all to continue to check back at our website at abta.org for other brain tumor related information. Our next 2 webinars are